Hello, everybody. Good morning, good afternoon, and good evening, depending on where you are joining us from. I'm very excited, happy, and proud today to kick off the 6th International Symposium on IUDs. You may know this was originally planned to be a day-and-a-half meeting in San Francisco last May, and as with everything else this year, COVID interfered with that original plan. So the organizing committee, who you see on the left-hand side of the slide here, regrouped, and we will now have 6 online symposia starting today. The next one will be December 9th, and the website will ultimately be your source for information on the dates and the programs as we move forward. The organizing committee, Diana Blythe, David Hubacher, Ricky Liu, Anita Nelson, Lisa Haddad, and myself have been enjoying planning this for a good time. There were 5 previous international symposia, and if you look at the February issue of Contraception, Jim Saylor and David Hubacher and I have an editorial going over the history of these meetings. It's been a long time since the previous meeting, so we're very happy to move it forward. And we had a mini meeting on May 26th, the date that the original symposium was scheduled, where we talked about the effect of COVID on contraception care and also about self-removal of IUDs, which was kind of a especially pertinent topic when women often could not come in to get medical care. So that was a bonus meeting, but today we're starting with our original agenda. Next slide. And you will see we have 2 panels today. The panel 1 is putting patients first, and panel 2 is the full global demography of IUD use. Now, I'm particularly excited about panel 1, which Raine-Bennett will moderate. In all of the past 5 symposia, we've covered all sorts of issues around IUD safety and efficacy in particular, around access, around regulation, and we will be getting to many of those topics during the later symposia. But none of the first meetings really thought about the patient voice. And so we felt that it would be really important to center everything we talk about over these 6 mini meetings around the patient, because what the patient wants and what the patient values is a very important part of the science as well. We have in Raine-Bennett from Kaiser Permanente to moderate an excellent panel to speak about the patient voice. And Tina is, as you see here, a senior research scientist at Kaiser. She also was professor at UCSF and has longstanding work in both public health, health policy, and all aspects of contraceptive access. And the second panel, David Hubacher will lead. David's been involved with several of the past symposia as well as this one. He has written extensively about the demographics of IUD use, and he's put together an outstanding panel for the demography. Now I want to turn it over to Tina to lead the first panel. Thank you.
Great, thanks, Carolyn. As Carolyn mentioned, historically, the prior IUD symposiums have focused on the epidemiology of IUD use and evaluations of product efficacy and safety. The goal of this session is to put a spotlight on IUD research and patient care from the patient-centered perspective. We hope to make connections to the research and demonstrate why it improves the quality of research when we consider centering patients. So we have 3 amazing panelists today, and I'm just going to introduce all 3, and they are going to do their presentations, and then we will take questions and answers at the end of the 3 presentations. And so I'll go ahead and get started. So our first panelist is Jamila Perritt. She is a fellowship-trained obstetrician and gynecologist with a comprehensive background in family planning and reproductive health. In addition to being the president and CEO of Physicians for Reproductive Health, an organization that uses medical evidence, training, and organized action to champion healthcare rights, she also works as a clinician in Washington, D.C., Maryland, and Virginia, providing on-the-ground, community-based care, focusing primarily on the intersection of sexual health, reproductive rights, and social justice. So she brings this amazing background to her presentation today. We also have Liza Fuentes, who is a senior research scientist at Guttmacher Institute, located in New York City. There, she conducts research on patient-centered access to contraception and abortion. Her research is focused on access to contraception, the evaluation of abortion restrictions, clinical training in reproductive health, and workplace sexual harassment. And we're happy to have us joining us to complement this panel. And then finally, we have Christine Dehlendorf, who is a family physician and reproductive health researcher at UCSF. She directs the Patient-Centered Reproductive Health Program, which aims to advance reproductive autonomy and well-being by conducting research and designing programs that center people's experiences and preferences for sexual and reproductive health and healthcare. Her work is guided by an attention to the intersecting oppressions and structural injustices that impact the lives and health of patients. And so I will turn it over to our first presenter, Jamila Perritt.
Thank you so much for that introduction, Dr. Raine-Bennett, and thank you all for joining us. My role here is really to set the groundwork for our talk today and hopefully for the remainder of the conference, while we're talking about patient-centeredness and most importantly, how we can use this moment to reframe our views on IUD access moving forward. You heard that we chose to begin this conference with a conversation about what it means to center those we care for in the work. And Dr. Westhoff mentioned in her welcome that this is not by accident. It is by design, and where we must always begin in clinical care, research development, and outcome measures. We begin with the people we care for, our patients, as a reminder of what brought us to the work in the first place, and a reminder of what we hope to achieve. And so we invite you to also be reminded with us today, understanding that as we begin, that it is just that, a beginning, a first step. Next slide. So much of the work in the contraceptive care and research space focuses on addressing health disparities. We talk about incidence of unintended pregnancy, abortion rates, contraception use disparities. We discuss unwanted pregnancies and contraceptive uptake disparities, and we seek solutions to address these differences. We identify and call it success. And the reality is that for our patients, there is more to the story. There's always more to the story. And in reality, individual and community experiences with contraception and pregnancy and abortion interact within a complex and complicated web that's overlaid in the social, political, back one slide, sorry, and social context in which we live and operate in this country. Decision-making for our patients is impacted by this context. Access to care is impacted by this context. And it's for this reason that we must understand that the way we view care delivery, research and development is also impacted. And so when we look at, for example, increasing access to IUDs, it's exactly why that doesn't necessarily translate into uptake of more IUDs or subsequent decreases in unintended or unwanted pregnancy. Next slide. There's a history here in this context, and the history is a complicated one. It's complicated, it's layered, it's messy, but it's also important. It's a history of reproductive oppression and abuse. It's a history of distrust and mistrust, of bias and discrimination. People of color and those who have low incomes or are living in poverty are historically less likely to have access to quality, culturally responsive, comprehensive reproductive health care, including access to IUDs if they want or need it. And these are same communities are more likely to experience bias and discrimination when seeking healthcare services, and are more likely to have experienced reproductive rights abuses, both at an individual, but also as a community level in the past. And as a result, are often more likely to report distrust in healthcare providers or the healthcare system more broadly. All of these things impact the ability of an individual to access reproductive healthcare services and impacts the desire for contraception and things like IUDs. The history of the communities we hope to center in our work, those who are most likely to be marginalized from care, is one that is built upon and grounded in the theories of stratified reproduction and beliefs about who should parent and who should not. We as providers and researchers are not uniquely exempt or excluded from this history. And in fact, our research, our scholarship supported, promoted, and reified these practices and beliefs. And it is all grounded in power and in privilege. Next slide. The ways that institutional and individual power and privilege play out in medicine and in research is something we rarely talk about. It's kind of like gravity. It's ever present, rarely if ever acknowledged, and always holding us down. It shows up in all that we do, from the way we problematize reproductive health disparities like unintended pregnancy or contraception use, to how we design new contraceptive methods. There's a hierarchy in clinical care and in knowledge production, and there's power in the white coat. We who hold positions of power decide what method is good or bad, right or wrong. More often than not, we decide what community needs, often without ever even asking the community. And this is how our values show up in the public space and in the patient care space. Some of you may recognize this list. It's adapted from Tima Okun's White Supremacy Culture, how white supremacy shows up in our work. And I'm including it here because so many of these values also show up in the way we practice medicine and the way we conduct our research. While we don't have time to go through this list in its entirety, I do want to lift up a few specifics as examples of the way that we, in our positions of privilege and power, are centered in the work as opposed to the patients we care for. Namely, power wording, either or thinking, and the presumption of and belief in objectivity as values we hold. These values are particularly relevant in the world of contraceptive development and care. We place little if any value around sharing power. And as the ones with power, we assume that we have the best practices of the patient or population at heart. We assume that those thinking differently, for example, patients not wanting to be pregnant and also not wanting an IUD, are simply ill-informed or inexperienced. This is closely tied to either or thinking, especially around contraceptive decision-making. If in reality you don't want to be pregnant, of course you would want to use the most effective method. There is no sense that things can and often are both and. And of course, this belief that there is a such thing as being objective. Our patients don't make decisions in a vacuum, and as clinicians and researchers, neither do we. We are shaped and influenced by our own lived experiences, our own biases, our own stories. And yet we convince ourselves and try to convince others that we are objective in our policies and practices. In contrast, centering our patients in the work looks very different. It looks like ensuring our actions are aligned with our actual values in this work. Next slide. If you think back to the beginning of my section when I urged you to remember why you came, now I want you to think back a little bit further, way back to when you were writing your personal statements for graduate school or medical school. If you were asked then what brought you to the work, maybe you would have said you held a different set of values that called you to do this work. maybe you would have identified things like the desire to make a difference, to address health inequities. Maybe you wanted to engage in critical thinking and research to improve health at a population level, or maybe even in your own community. The question then is, how do the values we say we hold, the ones we held then, measure up to our practices and the things our patients see from us in our research, our scholarship, and our clinical care? How do we operationalize and actualize these values? Are we transparent in our approaches to research? Is our research designed and implemented in partnership with our patients and with our community? Are these partnerships equitable? Who is accountable to whom when harm is done? How do we acknowledge, understand, and incorporate the history of the community in our practice? Next slide. Approaching this work through a lens that centers those we care for, our patients, demands that we continue to seek solutions that prioritize those most impacted by these inequities. In other words, aligning our values with our actions and designing systems and research that benefits those that need it most, as determined by them and not us. Organizing and prioritizing those on the margins of care ensures that if we can design systems that provide care for folks, for these folks, everyone else will benefit. Our research and clinical care continues to expand, to grow, and to change. But we cannot forget that even as those things change, often for our patients, the inequities remain. The importance of holding fast to this context as we protect and expand contraceptive care and specifically access to IUDs, it must be intentional, and it is absolutely necessary for seeking solutions to address these inequities in any meaningful and sustainable way. Thank you. Next slide.
Thanks, Jamila. And now we'll have Liza Fuentes presenting on patient-centered contraceptive access, contraceptive care, and IUD access.
Hi, everyone. So thank you so much, Dr. Perritt, for that. I'm going to talk a little bit following on more practically. I'm going to briefly discuss some dimensions of IUD access that illustrate the importance of ensuring patient preferences are incorporated into contraceptive service delivery and research. It may seem to go without saying that there are other dimensions of IUD access beyond being able to obtain one, but it is worth naming them because they have not always been prioritized in research, development, clinical training, and service delivery. The Institute of Medicine Framework for Quality of Healthcare is a useful guide for identifying these dimensions of contraceptive care and how they relate to IUDs specifically, so I'll just mention them briefly here. The Institute of Medicine Framework states that healthcare must be safe, so avoiding harm to patients from care that is intending to help them. We might argue that a great majority of IUD research historically has been focused on this aspect, and we're very happy to be able to say that from this perspective, IUDs that are available today are safe. Effectiveness, so providing services based on scientific knowledge to all who could benefit. We know that IUDs are effective in that they prevent pregnancy while they're being used. But another aspect of contraceptive effectiveness is the patient's ability and willingness to use the method. Indeed, the most effective contraceptive is the one that the patient will use. So that's a way to look at effectiveness from a patient perspective. The Institute of Medicine also names a dimension of quality of care as being care that is patient-centered overall. So providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. The ability for patients to switch from an IUD to other methods or from other methods to an IUD or have one removed falls squarely within this dimension. Timeliness, so reducing wait times and sometimes harmful delays for those both who receive care and those who give care. And so I'll touch briefly in this presentation on the timeliness of IUD removal. Care must be efficient, so avoiding waste, including the waste of equipment, supplies, ideas, and energy. This concept should not be misapplied by rationing or denying IUDs based on the perceived length of use of the contraceptive method. If an IUD is a patient's preferred method for the next 6 months or 9 months, then their ability to use it for the purposes that they see fit is an efficient use. And care should be equitable, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, etc. And so one of the things that falls under this is affordability, and the ways that we both attempt to address affordability by, for example, providing free IUDs in some contexts, and the way that the healthcare system makes IUDs affordable or not writ large fall under this. So I'm going to briefly review some literature that touches upon these concerns, both from other scholars and from me and my co-authors, Anu Gomez and Liza Stern, work that we've done in the past that illustrate some of these things. Next slide. So in addition to the quality of care framework, there are some specific concerns with IUDs that lead us to incorporate the assurance of patient preferences around IUD use, particularly with removal and method switching. A recent qualitative study, in one recent qualitative study, almost half of the participants receiving post-abortion contraceptive care reported feeling pressured or overly directed to use a certain method. And as the authors state, perceptions of coercion manifested as not being offered a range of options, not being given enough time to deliberate over contraceptive choice, being pressured to choose any method in order to avoid future abortions, and pressure to choose long-acting reversible contraceptions under which IUDs fall, specifically at times impacting participant behavior and trust. Unequal care also arises from implicit bias. This has also been well established by the Institute of Medicine, but there is research specifically related to contraceptive care also demonstrating that this shows up by our co-panelist, Christine Dehlendorf, specifically showing that people of color and low-income people may be more likely to be recommended IUDs, which are not appropriate dimensions by which to make clinical choices. And we also know that many reproductive health and social policies are coercive in nature, and the coerced and forced use of contraception is a historic and current reality. For just one example, very recently in 2017 and 2018, a judge in Tennessee implemented a program offering a 30-day reduction in jail sentences in exchange for obtaining Nexplanon. And dozens of women actually did obtain Nexplanon before the program was stopped and the judge was reprimanded. And coercion is central to many reproductive health funding policies. In one of the more salient examples, the Hyde Amendment prevents people from using Medicaid to pay for abortion care. Additionally, recent policies attempt to restrict contraceptive choice by allowing employers not to cover certain methods for religious or moral reasons. Next slide, please. Additionally, there's half a dozen research articles that show that 15 to 20% of people who obtain IUDs will seek removal within a year, and many more will want a removal before the recommended maximum years of use. So this dimension of patient-centered IUD care is not simply philosophical, but it's a practical need to meet the needs of people using care. Even more importantly, removal and placement is primarily clinician dependent, and so it depends on the research and clinical practice community to ensure that patient preferences are met with respect to this dimension. Next slide, please. So what do we know research-wise about these different dimensions of IUD care? Well, there are a few studies that demonstrate, that we still have work to be done in both research, clinical training, and service delivery to meet patient preferences with respect to IUDs. In one recent study, participants reported feeling, a qualitative study, that healthcare providers' preferences for the patient's contraceptive choice took precedence over their own preferences, including feeling pressured to keep a long-acting reversible form of contraception, including IUDs, after requesting removal. In another study of patients requesting, quote, early removal, researchers found that although the participants generally requested LARC removal, which includes IUDs, after waiting for adverse symptoms to resolve, they still felt that providers had a preference for them to continue to use the method. And in a study of health providers seeing patients with removal requests, the authors found that providers had negative feelings about what they perceived as too early of removal requests, including frustration with the supposed wasted cost, as well as feeling as if they failed if the patient is unhappy with the method after they recommended it. They also reported encouraging LARC continuation, including IUD continuation among those who requested it, especially if they felt IUD removal conflicted with what they perceived as patients' reproductive goals. Next slide, please. In addition to the Institute of Medicine, the World Health Organization report ensuring human rights in the provision of contraception information and services also underscores that quality of care includes attending to patient preferences, regarding insertion, removal services, counseling on side effects in the same locality. So even with these few research articles, when we look at these frameworks, we're seeing that we still have some space to improve upon meeting patient preferences. Next slide. I'm going to review some research conducted by Anu Gomez, Lisa Stern, and I recently around IUD removal, length of use, to continue to illustrate some of the need to meet patient preferences around these different dimensions. Next slide. We surveyed over 2,000 patients about their anticipated need to remove a LARC. And when we asked how difficult or easy they thought it would be arranged to get their LARC removed when they wanted to, we found that although 3/4 thought they felt that it would be easy, nearly 15% thought it would be difficult. Here's an opportunity to look into why they think it would be difficult and see where along these other dimensions of quality of care we need to improve to ensure that doesn't happen. Next slide, please. When we asked why they thought it would be difficult to remove, 15% of patients said they thought it would be difficult to remove because they don't know where to go to get it removed. This is a critical aspect of quality of care. So again, this gives us some insights into the fact that while many people may be happy with their IUD use, some people still have some aspects and dimensions of this care that need to be addressed. Can you go on to the next slide, please? This slide is kind of busy, but I've circled the important part, which is that when we ask people among IUD users, if a provider had ever refused to remove their LARC, 5% out of over 2,000 said that that was the case. This clearly doesn't meet patient preferences. Next slide, please. We also surveyed former IUD and implant users. Some of this will focus specifically on IUDs, as this is the nature of this presentation. Next slide. This is not from our survey, but rather an analysis we did a few years ago from the National Survey of Family Growth. And while we have not updated these analyses, the point remains that over time, the proportion of women who reported discontinuing IUDs owing to dissatisfaction increased in the last decade from 32% to 52%. In both time periods, women who did not cite dissatisfaction as a reason for discontinuation also had longer mean durations of IUD use. On its face, this is not problematic. If people are dissatisfied with their IUD, they should be able to get them removed. What these data demonstrate is that as more people use IUDs, many of whom may be trying them out because they've become more available at their facility or more affordable where they get care, for some proportion of users, they simply won't be the right fit, or they'll want to remove or switch them at intervals that should not be dictated by provider perception about what is the correct length of use, but rather the patient's needs to either use another method, plan for a pregnancy, or any other reason. Next slide, please. We also looked at the National Survey of Family Growth over this time period to look at the average duration of use that was less than 12 months. And we found that the proportion of women who used IUDs for shorter periods of time also increased from the 2011 to 2013 time period to the 2006 to 2010 time period. So while 23% of women had a mean duration of 12 months or less earlier in the decade, this proportion increased to 37% later on. Again, as IUDs may have become more available during this time, including more affordable because of the Affordable Care Act, more accessible at facilities who've actually been able to train up and stock their facilities with these devices, and changing clinical training that allows women to get IUDs placed even if they haven't finished childbearing. This means removal and switching is more common because people want to plan for a pregnancy after having received an IUD, or simply use a different method since they're earlier on in their contraceptive careers. Or people simply found that IUDs were not a good fit for them. Next slide. In terms of timeliness, in this slide, the orange sections of every bar is the overall proportion of respondents in our survey who said they got their LARC removed later than they wanted. The green is the proportion who said they get it out as soon as they wanted. If you look, each bar represents a different state in which we conducted the survey, but if you look at the last bar, overall, 27%, so over a quarter of respondents said they got their LARC out later than they wanted. Next slide. And while people's assessment of the timeliness of their care is important, we also wanted to know how that compared to the actual timing of when they got their device removed. This chart shows the percent of respondents who got their LARC removal more than 2 months after deciding on removal. Those who said they got their LARC out later than they wanted, the orange bars, were more likely to have a removal more than 2 months after deciding, compared to those who got it out as soon as they wanted, which is the green bars. And at the end where the circle is the total for the entire sample. So among all respondents, 39% of those who got a LARC removal later than they wanted got it out more than 2 months after deciding, compared to those who said they got it out as soon as they wanted, for whom only 16% got it out more than 2 months after deciding. This isn't to say that delays in IUD removal are particularly salient compared to other types of contraceptive care. We didn't measure that, but it is to say that the dimension of timeliness is an important one with respect to IUD services. Next slide, please. When we asked why people got their LARC removed later than they wanted, this was the breakdown of the major reasons. For 38%, they could not get a sooner appointment. And I also like to, for 23%, they said their provider encouraged them to keep it. And 11% said that they had difficulty finding a provider. This gives us some insight into some of the ways that we can improve timeliness and patient preferences with aspect to IUD care. Next slide, please. When we asked everyone who had a recent LARC removal how difficult or easy it was to arrange to get the device removed, 20% said it was difficult. So while it's encouraging that for most people they thought it was easy, 20% is not a small proportion of people. And this leads us to think about within our patient panels, within our facilities, within our practice groups, what proportion of people may be having that experience and why, to improve patient care. Next slide. So I just quickly reviewed some research and some figures that provide some practical illustration of the way that the full range of dimensions in IUD care must be met in order to meet patient preferences and overall quality of care. It's imperative that patients' preferences regarding all aspects of IUD use are met, and contraceptive research, clinical training, and service delivery must incorporate these critical dimensions. This is important not just to ensure quality of care within our institutions and high quality research within our research agendas. I mean, that is important. Otherwise, the fact that IUDs are highly effective means very little to patients if we can't meet their preferences. But it's also important because as we've seen before, the suggestion of or the actual deployment of devices like IUDs to meet social policies, such as reduced sentencing, or other types of things, need to be vociferously opposed by our communities that are committed to patient preference and care. Next slide, please. The work that was presented here was conducted in partnership with Anu Gomez and her team at UC Berkeley, Lisa Stern and her team at Planned Parenthood Northern California. And our original research was funded by Society of Family Planning Research Fund. Thank you.
Thanks, Liza. And so now we'll move on to Christine Dehlendorf, who's going to round off this presentation talking about tools for patient-centered IUD care.
Thank you so much. It's a real honor to be following Dr. Perritt and Dr. Fuentes and to work alongside them in the ongoing efforts to make sure that the care that we provide is both historically and socially contextualized with relationship to IUDs and all aspects of contraceptive care. And also, I really just want to appreciate Dr. Fuentes and her colleagues for the work that they've done to remind us that it's not that our focus in family planning and contraceptive care is so often about getting whether or not patients quote unquote get on a method or leave with a method and don't think about their experience of the use of the method afterwards, in addition to how we can continue to improve their reproductive well-being after they leave the clinic. And that's a critically important point. My own work and focus is often on this question of how we support patients when they're choosing a method. So that's going to be what I'm going to talk about today. But to do that, I want to first reground us, next slide please, in the concepts of patient-centered care, which both Jamila and Liza mentioned and are really why we're talking about all of this today in the first place. Patient-centered care seems like an incredibly obvious concept that shouldn't all care be patient-centered, but we also know that in reality, partly based on the historical nature of how our healthcare institutions have been created, in fact, oftentimes the care we provide in general in healthcare is grounded in the priorities of public health and other clinical systems. So the Institute of Medicine, in the publication that Liza referenced, really brought patient-centered care to the forefront, but this was only in 2001 when they defined it as one of the core dimensions of quality. And in that, they defined it, although I would argue that Dr. Perritt probably defined patient-centered care better than the Institute of Medicine. But in this publication, they defined it as care that is respectful of and responsive to individual patient preferences, needs, and values. And this really goes to the fact that the clinician doesn't know best. It is the patient who knows best. And our job is to be in service to the patient in terms of achieving their goals. And I want to reference the insights of my colleague Sharice Scott from Tennessee and Sister Reach, who has really pushed me to recognize the way that even while patient-centered care is a core dimension of how I think about this work, it really should be patient-led care, because patient-centered care still puts the agency and the provider to center the patient, whereas really we should be following the leads of our patients. So clearly patient-centered or patient-led care is an ethical mandate. In addition, not surprisingly, when we center what patients need and want, they are better able to engage with our care. They're better able to get the care that we want. And this has been found in systematic reviews and lots of literature. So I just want to emphasize, this is not an either or thing. This is not a balance. This is meeting patients' needs, and that is meeting patients' needs for clinical care and for their values and preferences. So I want to focus a lot on the question of communication and counseling specifically, because really that is where the rubber has met the road a lot in terms of how our enthusiasm for IUDs and implants has, and this idea that, as Jamila referenced, that providers know that patients should want to use these methods because they should want to prevent an unintended pregnancy, with that either or thinking, where that enthusiasm has gone towards directive counseling towards IUDs and implants in a way that has unfortunately, we've seen in literature and research, has unfortunately led our field to at times, and I would say often, neglect individual patient preferences, needs, and values with respect to what methods they want to use. We know from the literature that there is a broad range of preferences for methods. Many patients value effectiveness, but some patients value other things more or as much as effectiveness, including things like whether or not they're able to remove the method on their own time. And as we know, self-removal of IUD is a hot topic, but most patients can't do that in the studies that have looked at this. So patient control is incredibly important. Being able to not have menstrual abnormalities. All of those things are things that matter to patients. And so patient-centered counseling around contraception, including IUDs, needs to include recognizing that patients have different preferences and values with respect to the importance of avoiding a quote-unquote unintended pregnancy and other method characteristics that are relevant to their method choice. So how do we provide this patient-centered contraceptive counseling? Well, I think there's a lot of work out there about how we can provide shared decision-making, how we can support patients. And I just want to reference, though, that a lot of it is just the question of what attitude we go into counseling with. Do we know what's better, or do patients know what is better? And it's our job to provide them with the information that allows them to match what we know about methods with their own preferences and choose the method that is the best fit for their preference. And so really what we need to be doing is reconceptualizing how we think about counseling in the first place. That said, I will also say that there are ways that our healthcare systems and structures incentivize or push us towards certain aspects of counseling and more directed counseling towards specific methods that we can think of and we can think about changing, so that instead of the hardwiring in our clinical systems be towards IUDs and implants and towards counseling towards those methods, we instead shift the way that our default pathways in our clinical programs are towards patient-centered care specifically, and trusting patients to know what is best for them. So next slide, please. So as an example of that, I think many of us have seen this, this chart, an effectiveness MACE chart for contraceptive methods. This is what has been often called an evidence-based counseling tool. And it is an evidence-based counseling tool in that it has been found in a study to improve patients' knowledge about relative and absolute effectiveness of contraceptive methods. And that is important. However, the problem is that this tool, or ones like it, have been used not just to counsel about effectiveness, but rather to structure counseling overall. And what that means is that by structuring counseling around effectiveness, we prioritize and foreground that aspect of method choice and method characteristics, and therefore demote other aspects of method characteristics that may be more or equally important to people. Next slide. Here's another example of a chart that is obviously much prettier than the other one that has been increasingly used. And this, though, falls into the same category. This may improve patients' ability to make decisions about contraceptive methods, but it also prioritizes and lifts up effectiveness over other aspects of method continuation or method use and method characteristics. And I also want to call your attention to the right side, where it talks about the chances of getting pregnant and the way that this, what's called a risk array, is done. And I will come back to this in a second, because I think that the way this is done, where the bottom part says less than 1 in 100 women, but there aren't actually 100 options, 100 spots filled out. There's only approximately 21. That is one of the subtle ways that we use statistics around IUDs and implants to lift them up as even better methods than they might be in reality, and with the goal of getting people to consider them more at a higher level than they would otherwise. And I'll explain more what I mean by that when I come to another slide. All right, so what's the alternative? So these types of tools, either the CDC one or this one, are in clinics all over the country, right? And they're often the tool that's available. And so the default pathway is that we counsel using these tools, the medical assistants, the health educators, whoever. This is what patients see as what we're interacting with. And that prioritizes effectiveness and therefore deprioritizes patient-centered care focused on other aspects of methods that people may want to talk about. So next slide. So here's an example of a job aid that, instead of focusing only on effectiveness, talks about effectiveness in the context of other method characteristics. And this is from the Family Planning National Training Center, the Title X National Training Center, all freely available government resource. You can find this on fpntc.org. And the goal of this is to be an evidence-based tool. All of these, I worked with them on this tool. All of the data points are referenced and based on good research. And it includes risk of pregnancy, which I think is a more interpretable concept than effectiveness for people. Risk of pregnancy, but it also includes other things that people will care about. And it allows patients to think about how they consider effectiveness or risk of pregnancy compared to these other characteristics. And I have heard from many people when they look at this that it's overwhelming. Yes, it is overwhelming if you just hand this to a patient. This is not something that you can just hand to them. But the reality is we are lucky to have a lot of contraceptive methods, not enough variety, not enough that meet everyone's preferences, but we are lucky to have a lot of methods. And if we are going to do a good job of counseling patients, we need to make sure they know about their options. And that means getting into details with them. But this tool can allow people to do that in a structured way. So for example, if we find out that a woman really doesn't want to get pregnant, that that's really important to her, we can indicate to her on this tool what methods are most effective at preventing pregnancy. Can you next click? Or let's actually, how often the method is used. It's really important for her to not to have to think about a method. I forgot where my circle was, my apologies. It's really important for her not to use a pregnancy and not to have to think about her method frequently. So then we know that this is the methods that fit that aspect of her preferences. But what if she also really, really wants to have improvement in her acne? Next slide, next click. That takes us down here. And this allows her to this patient to visually see that these two preferences for her method characteristics don't align and allow her to determine which one of her preferences are most important, as opposed to us making the assumption that it would be effectiveness. Next slide. So that's one example of how shifting what patient education materials or job aids we use in a clinical setting can be effective with promoting patient-centered care and centering the care that we're providing on patients' needs, values, and preferences. I'm going to just briefly mention a tool that we developed at the Person-Centered Reproductive Health Program, which is designed to be a more comprehensive approach to this for decision support and actually take this out of the hands of the provider, what decision support is provided, because we all know that people get unstandardized counseling and it's hard as a provider to not be biased. And so the goal of this tool was to make sure that all patients had information about the ways methods varied and how their preferences related to the ways methods varied before they go into their visit, so that they can then be able and facilitated with getting the care that they need based on their preferences. So next slide, really quickly, as I have referenced before, we really need to be talking to patients about effectiveness because a lot of patients really value effectiveness, and we want to make sure that patients know about their options and how their options vary by effectiveness. So best practices for risk communication are to use this type of risk array where you don't cut off, this that takes me back that the previous chart that I showed you where they only use like 21 people to indicate a risk related to 100 is like how to lie with statistics, right? From my 6th grade math class, you have to show people the full number, the full denominator that you're dealing with to do an accurate job of risk communication. So this is how we do it, and we allow people to interactively click through the different options so that they can see visually how things interrelate. Importantly, in this tool, we also recognize that many people don't know about IUDs or they have misperceptions about them. So we do address that. And we address it about other methods as well, including emergency contraception. But we do it in a way that's not like you should use this method. We do it in a way that's like we want you to have all the information that you need to make the best choice for you. Next slide. And most importantly, we don't only talk about effectiveness, and we don't put effectiveness first. I talked about it first because that's the content we're addressing in this symposium, but we talk about how often methods are used, how you take your methods. These are all the different screenshots from the different modules, side effects of the methods and how it affects future fertility. And then we walk through a decision support process where we allow people to think about what's important to them and to get a series of recommendations for what's important to them. But we don't put it into an algorithm with no transparency, which some decision support tools that you'll see on the internet do, and it often gives you IUDs and implants as your response, as the end result. We actually give people a range of recommendations based on the different types of preferences they have. So this is just an example of how we really need to be thoughtful about the patient education tools that we're using when we are providing patient care, and how they implicitly or explicitly reflect values about what is important in terms of patient preferences, and whether or not we think that the patients should be given information to make the decision that's best for them, or if we should be giving them information that we think will lead them toward the decision that we think is best for them. And I will just say briefly that we've tested this tool in a randomized controlled trial and found that it was positively associated with patient experience and with decreased decision conflict about what method that they chose. Okay, next slide. So in addition to what patient tools we use in the clinic, we also have to think about how are we researching and evaluating care. I don't have time to do this whole topic justice, but I will say that we really need to think critically about our outcomes in general in the contraceptive field. We already heard reference to unintended pregnancy and what a problematic term it is. In addition, contraceptive continuation. Liza's whole presentation is about how contraceptive continuation needs to not be prioritized as an outcome, and often that is in our trials. That is what we prioritize, and we really need to be thinking critically about how we're foregrounding patient preferences, reproductive well-being, reproductive autonomy, as opposed to outcomes that are defined by clinical and public health priorities. One particular place where this is really relevant is in this big ongoing landscape of work that's being done around quality metrics in contraceptive care, which has been fueled by the desire to make sure that contraceptive care doesn't get left behind in the drive towards quality metrics, where what gets measured gets prioritized. And coming out of that recognition, there was an effort by Planned Parenthood and CDC and OPA, among others, to get methods, performance measures of contraceptive care endorsed by the National Quality Forum, and this happened in 2016. And you can see these measures up here, that there is measures of provision of long-acting reversible LARC methods as a quality metric. What percentage of women of reproductive age in a given calendar year were given an IUD or an implant? And then the same thing postpartum as well. So this raised a lot of concerns appropriately when this was initially proposed and when it was endorsed, because this can feed into directive counseling. We know performance measures have impacts that are unintentional. And in this case, saying that provision of long-acting contraception is a quality metric implies a more is better model that can lead to directive counseling. And again, as Liza referenced, this is more likely to be directed towards communities and populations who have and continue to experience reproductive coercion, most notably women of color. Next slide. So the Office of Population Affairs, who's the steward for this measure, really recognized this as a concern, and they made efforts to mitigate this in their messaging around the measures when it was approved. And this is from their website, where they talk about that this LARC measure is not designed to be a more is better measure. It's designed to be a floor measure that marks whether or not basically any LARCs are being provided in a given facility, so that patients can know that they won't experience barriers to getting an IUD or an implant if they go to a given clinic, is the idea from patient reporting, and to incentivize on-site delivery of IUDs and implants, which is and has been a problem. And so if used appropriately, this is a measure that has the potential to alleviate aspects of the quality of deficits in quality consistent with the IOM, dimensions that Liza elucidated. However, the problem is that this is not always going to be the case, that people don't always implement things the way they're meant to be messaged. So this is something that we have to be paying attention to in terms of how this plays out on the ground. Next slide. In addition, one of the other things OPA did was to fund our team at the Person-Centered Reproductive Health Program to develop and validate a patient-reported quality metric that we have submitted for endorsement to NQF and is expected to be approved next month, I believe, as an endorsed measure that measures actually are patients by their own report getting care that they need. Are they getting care focused on their values and preferences? And if we see IUD rates go up and we see patient report of whether or not they're being respected as a person, whether or not they're being able to say what mattered to me about their birth control method and their preferences are being taken seriously, if scores on that are going down, then we're able to mark that that's a problem and be able to intervene appropriately. And really importantly, I will just say that when we did a pilot study with this tool, we found huge disparities by race, ethnicity, and by language, by Spanish versus English in reports on this measure. Next slide. So I just want to close by referencing the fact that all this work, this desire to hardwire patient-centered, patient-led counseling into contraceptive care needs to be community and patient-led. And I want to reference the work of the National Women's Health Network and Sister Song on their joint statement on the principles of LARC, which has been signed by hundreds of people at this website. You can find it, where they really state what the community wants from the care that we provide with respect to LARC. And they say we commit to ensuring that people are providing comprehensively, scientifically accurate information about the full range of options in a medically ethical and culturally competent manner in order to ensure that each person is supported in identifying the method that best meets their needs. Thank you very much.
Great. Thank you, Christine and Liza and Jamila, for excellent presentations, giving us a really broad perspective on how we can center patients in IUD care. So let's see, there've been a few comments in the chat, and I just want to say that this symposium is being recorded, and the symposiums will be available, and we will also make the slides from the presenters available. There were a couple questions specifically for Christine about the decision support tools that were presented. And I think those slides will be available, and there's a question about whether or not they're publicly available. Christine,
Yes.
Do you want to just address that?
I just put the link in the chat or in the Q&A, I think. Hopefully people can see that. And I'm happy to answer questions. We have implementation materials as well. Right now it's optimized for a tablet, but we are on the verge of launching a responsive design that is available, that will be worked on phones and on laptops.
So let's see, we have some questions coming in the chat. So one of the questions from Maureen Baldwin is, it seems that a barrier to measuring access to appropriate removal services is a lack of specific diagnosis codes for instrumented IUD removal. Do you agree? And do you know of any efforts to measure difficult IUD removal more accurately? And that was to any of the panelists.
I will say, sorry, Liza, if you know anything, please, I was going to say, I know nothing.
I don't know anything about this. All I do know is that certainly our research to date has not focused on the provider side, although we've been interested in it. But what we've heard anecdotally is that billing codes for removal broadly is a problem, and being able to incorporate that service and be compensated for it properly. For difficult removal, I don't know anything. So go ahead, Christine.
No, I think that's sorry, Tina, do you know anything?
No, but I was saying it seems to me that our coding in and of itself for like coding removal reasons could be give a wealth of information about satisfaction and as you mentioned, difficulty removing IUDs as well. Mm-hmm.
And I will just say that in the performance measure space, I think this would be a really, we've been thinking about what needs to be in general prioritized as we move forward with thinking more comprehensively about quality. And I think that would be an important area to think about, that where coding would be of IUDs removals would be really helpful.
Let's see, there's a question from Mallory Stonehouse. The method choosing tools look promising, but she noticed that there's some gendered language, and she was wondering if there's any work being done to avoid exclusion of people who do not identify as women but are seeking contraceptive care.
Yes, thank you for that point. That is part of the revisions that we are working on in this round as we move towards responsive design. So my apologies for not mentioning that.
Let's see. So based on the presentation, I think it brings up a lot of questions about how can these principles inform traditional clinical research on safety and effectiveness. So how, and I would ask the panelists, how can this shift our research priorities for IUD research?
I think part of it in the earliest place that I would start was really thinking about who's asking the question and who's seeking the answer, right? And so as we're thinking about who we're designing care for, you know, the idea that we need 30 different IUDs was decided, I think, by, I would ask, by whom, right? And so even from the idea of where the research begins, what questions we're asking, often it's very different if you aren't the one that's receiving the care. So there are models for actually crafting, creating, designing research that centers in the, with the community and lives with the community. But it's everything from designing the research question to what we do with the data when we collect it, right? How do we share it back to the community? How do they understand, the folks that we're serving understand the role that they've played in participation in the research? And what do we feel our obligations are to do so? There are lots of structures that prevent that from happening. Firewalls, you know, to access research articles even is a really big one. And then data ownership, this idea that you could mine data from a community and then they no longer have access to that data at all. So it really requires a deep dig in all of our research practices as we're thinking about transforming care to decenter ourselves and instead to center the people we care for.
Thank you. There's a question from Ricky Liu. Often the challenge is at the frontline public health facility or just in our clinical practices where we have limited time in our patient encounters. Do any of the panelists have ideas about what we can do to redesign the experience of care?
Well, I definitely
I'll go
feel.
again.
No, go ahead, Jamila. Go ahead.
So I'll start again, and then please, Christine, join in. I think, you know, part of it is thinking about who's providing the care and what. I'm not sure what the person who posed the question meant about healthcare workers, but you know, when we talk with patients about the care that they receive, the power dynamic that exists between clinician providers, whether they're physicians or APCs, and for example, frontline staff, often impacts the experience of care. And so for models that have more of a power sharing model, where oftentimes our frontline staff folks are folks that come from the community. And so the experience is very different for our patients when they see themselves reflected in the care providers. And so that's one way to start, right? So we don't need 1,000 more physicians in the community to provide care, but how are we really leveling the playing field and including folks that are from the community in the care experience? I think the other thing that's important to think about, sorry, I'll say this last thing and then make room, would be really what we mean about the experience, with that phrase, the experience of care. And sometimes it's referred to as patient experience, for example. And I would encourage us to think of it less in that way and more about how does the person that is receiving the care understand the values that we hold in this space, right? And so if we value agency, autonomy, inclusivity, we value empowered decision-making of the person receiving care, how does that actually show up when we're taking care of people, and do our policies and practices align with those things? And I think that leading with those values is the way that we improve patient experience or the experience of care.
Thank you, Jamila. And I want to thank all of our panelists. we have run out of time, and there are several more questions in the chat. We will be providing these questions to the panelists, and they will provide answers, and we'll provide those to attendees. So we have to end now. And again, I want to thank the panelists. This has been a really stimulating and interesting presentation and food for thought for the rest of the symposium. So I'm going to turn it over to David, who is going to begin our second panel. Thanks.
Thank you, Tina, and thank you, presenters. My name is David Hubacher. I'm a member of the steering committee for this IUD Symposium. In the first session of this panel, we're going to share some information about worldwide use of IUDs, including country and region-specific information. And so for the first presentation, we're fortunate to have Dr. Moazzam Ali from the World Health Organization. He is in the Department of Sexual and Reproductive Health and Research at WHO, where he has authored numerous papers on IUD access over the years. So I'll turn it over to Moazzam.
Thank you very much, David, and good morning and afternoon, everyone. Thanks very much for the introduction and the opportunity to present in the symposium. In this presentation, I'll provide an overview of the IUD use, issues in access, and some trends of use over time with regard to its share in the modern method mix in contraception. Next, please. Next, please. WHO undertook this review of literature in 2017 and 18 to look at the IUD use, the challenges in access through the review of the literature since 2010. And we also conducted secondary analysis from the UNPD, DHS, FP 2020, and other effort mayors, FB effort mayors. And we, in addition to that, we also wanted to have a look at the policy aspect. So we also conducted a survey for which we received 69 responses from countries. So just to have a look at a better understanding from the policy aspect regarding the restriction in use and what are the key challenges in different countries. Next, please. I'll begin with looking at the IUD prevalence across the globe, and wanted to highlight that the global contraceptive prevalence for modern method is 56%, and the proportion of IUD is 13%. And if you look at the low income and low and middle income countries, the prevalence is around 4%, which is the proportion among the modern method mix, which is 29%, and 5% in low and middle income countries out of the proportion of 46% of modern method mix. Now, I think this is also important to note here, although the IUD proportion looks 13% at this stage, which converts to around 250 million women globally. But actually, looking more closely, we'll note that in China, the prevalence of the IUD is around 41%, which turns into a number which is around 141 million women. So this high use and prevalence basically drives the global statistics. So if we exclude China from the global numbers, the IUD use will come down to 6% only. Looking at other areas and regions, Africa 4%, Sub-Saharan Africa 1%, America 7%, Latin America and Caribbean 6%, Asia 16%, and Europe 11%. I think it is also just wanted to highlight that once a method becomes widely available and accepted, the forces of familiarity both among the providers and the users become very strong. And there are also important to note that sometimes the policy decision play a major role regarding how it is used in a country. For example, in China, Vietnam, the former countries in USSR and Tunisia, and I'll show in the coming slide. Next, please. This is just to give an overview, and this is basically coming from the data from the DHS and FP 2020 databases, which we analyzed, and we looked at it to see and understand the IUD's current share of modern method among the modern method mix from 159 countries. Looking at it, you note that there are around 63 countries where the share of IUD in the modern method mix is around less than 5%. There are 32 countries with 5 to 9% IUD share, 10 to 9% in 28 countries, 20 to 29% in 21 countries, and 40% plus in 16 countries, which include the countries in former USSR, China, North Korea, Vietnam, Palestine, Sri Lanka, Jordan, and Tunisia, to name a few. Next, please. Now, this is another important aspect, availability and access. Access is a multifaceted concept which encompasses service-related dimensions, including the method availability, provider who is trained and is willing to provide the services, the travel time to the supply source, the cost, and furthermore, the client-related dimension, which include the knowledge, the attitude of regarding the use of the method. In the next slide, I'll show what is the informational access, and also then we'll look at the availability in different countries. Next, please. Awareness of methods and where it can be obtained, as I mentioned, is the cornerstone of access. As you can see that among 22 of the 36 African countries, less than 50% have informational access. And once the informational access, I mean, where to obtain, how to obtain, and where is the supply source is not available, it becomes very difficult for the women to obtain these services. Next, please. However, if we look at other areas and countries, it is much higher. As you can see in different countries in Asia, Europe, and Latin America, it is more than 50% in most of the countries. Next, please. This is coming from the facility surveys from DHS and also FP 2020. The health facility survey, the basic idea was to look at the availability of IUDs in the facilities. Now, if you look at it, it's, as I've written, it is surprisingly high in view of the very low level of use in many of these countries. But it is still lower than the implants if you would like to compare it with that. There is, however, little evidence, when we were looking at the literature, there's little evidence on the presence of the staff trained to perform the insertions. So, I mean, that can be one factor. And if you look at more closely, there are, for example, 4 countries, Burkina Faso, Indonesia, Senegal, and Uganda, where you see very little difference among regarding the availability of the IUD and implants. Next, please. Now, this is the survey that WHO conducted, and we were able to obtain results from 69 countries, where we wanted to look at regarding the policies in access, in availability and accessibility, and the different restrictions that go along with the IUD use. We first of all noted that all countries except 8, there were formal policies on IUD use, and there were guidelines available. However, in sub-Saharan Africa, 22 of the 25 countries obtain free supplies from the donors. However, in other regions, the governments are much more likely to have to pay for the supplies, especially in the Latin American countries and also in South Asia. Similarly, services for immediate postpartum were available in 14 out of 21 countries in sub-Saharan Africa. Next, please. Continuing with the WHO survey, we also noted that although theoretically the IUDs are free in many low and middle income countries, but 30% of the users still rely on the private sector to obtain IUDs. So this is a very significant number in those countries where we think IUD is supplied free of cost. I think to take one moment, just to highlight that in most of the countries, the IUDs, when we say IUDs, the IUDs are copper IUDs that are used in majority of the countries. However, in US, for example, the prevalence of the copper IUD is around 24%. So hormonal IUDs are becoming more popular, but still there is time that they become, equally important or equal in numbers to as the copper IUD is at global level. In upper income countries, again, like I mentioned, cost is a big issue. And sometimes because of the medical coverage, the insurance, it becomes very difficult for many women to obtain the IUD services, whether it is copper IUD or LNG IUS. Restrictions, that is another area, very important area that we wanted to look at. And we noted that especially in North African countries and Western Asian countries, there is provision is only restricted to the medical doctors. So I think this is another area I just wanted to highlight, that this is another reason why sometimes IUD become difficult to access, especially in those countries where there are shortages of trained and skilled workers. Eligibility criteria is another one in which we noted that, especially in the most LMIC, the low and middle income countries, the policies prevent and discourage the IUD provision for the teenagers and the nulliparous women, and also those with a high risk of STIs. Next, please. From here onwards, there are 4 or 5 slides where I would like to show the long-term trends, country trends in IUD share in the modern method, and I'll take you through, over different regions. So overall, we see a decline. If you look at the slide, we see a decline over time. And the reason when we were looking at the literature was that over a period of time, the copper IUD was mainly replaced by injectables in many of these countries. And recently, the implant is also, becoming very popular. The relative influence of the provider and client preference in these situations is unknown, and probably it is very important, and both are, implicated in, having this sort of scenario. So if you look at this specific figure, looking at the Eastern, Middle, South, and Western Africa, you see that the IUD share is low except in Kenya in the 1980s, followed 10 years later on by Nigeria, but then there is a downward trend. Next, please. This is looking at South America. In South America, the popularity of IUD has clearly fallen. If you look at the trends in Bolivia and Peru, they are strikingly increased in rise, and then there is a steep fall. When we were looking at the literature, they were basically replaced by injectable contraceptives. Next, please. Central America, there is a steep fall in Honduras and Nicaragua. If you look at earlier on, there was quite high proportion of IUD use in these countries, but then it went down. Next, please. In Western Asia, the pattern is of a steep rise in IUD share of modern method between 1975 to 2000, and it is then followed by a plateau. If you look at Syria, Jordan, Turkey, there is still a high number, especially in Syria and Jordan, but in other countries, they remain stable in later part. Next, please. Southern Asia, again, you see a little bit of upward trend in Iran and downward trend in Bangladesh. Sri Lanka is a very interesting example where we see a 30% share of copper IUD in the 70s, which went down to 5% in the 80s, and then rose back to 12% in the early 2000s. So, I mean, this is a sort of a picture coming from Southern Asia. Next, please. Now, looking at North and Western Europe, you can see that the reliance of IUD is very high in Norway and France. Although despite that there is a decline in both these countries, owing to most likely injectables and implants and others, which replace copper IUD. And then there is a less, Germany is another interesting case. If you look at, this is orange in color, we see a sharp decline in the 1980s, followed by a plateau in the 90s. And the possible explanation was that there was a widening of choice after the reunification of the Berlin, East and West Germany, where the availability of the choices become better. So we see a little bit different pattern compared to other countries. Next, please. Now the challenges in sub-Saharan Africa, implants are proving more popular than IUDs as of recent. And there are also challenges, not only, I mean, regarding the availability, but there are challenges in the provider bias regarding IUDs because of not only complexity of delivery, but also outdated beliefs about, connecting IUDs with pelvic inflammatory disease, ectopic pregnancies, infertility. So it is very difficult to eradicate these outdated beliefs among these service providers, especially in the general practitioner, not in the specialist. Of course, in some of the countries where we were looking very closely, it was also noted that it is, especially in Brazil, for example, we were noting that many service providers mentioned that they were not feeling very confident of IUD insertion and removal because over a period of time, the number of patients become very less, and they lost the skills, or they were less confident in doing insertion and removal. So, I mean, these are some of the key challenges when we talk about IUD increased availability and accessibility. Next, please. Of course, we also see silver lining. The projects of the non-governmental organization also show that women want IUD when given an opportunity, owing to their effectiveness, owing to their long-term use, and the demand, especially in the East Africa, is increasing for not only limiting, but fertility control. And they are looking at long-acting reversible contraceptive, including the IUDs and also the subdermal implants. Then there is another opportunity. The trend towards institutional delivery is increasing in many countries in Africa, in South Asia, which offers opportunity for postpartum insertions of IUDs. And again, lastly, the last point is the cost of IUD is also falling. And the rollout in the low and middle income countries might succeed, as the cost of copper IUD is already very low, but LNG IUS is also falling. So that may help many countries to roll out these contraceptive campaigns, especially looking at the long-acting reversible contraceptive more successful. Thank you very much.
Thank you, Moazzam, for that great presentation. Our next speaker is Dr. Megan Kavanaugh. Many of you know Megan and her many contributions to our field. She is a principal research scientist at the Hubacher Institute. Megan's going to share information on IUD use patterns in the United States. All yours, Megan.
Hi, everyone. Thanks, David, Carolyn, and to the whole organizing committee for the invitation to share with you today some trends on IUD use here in the United States. Next slide, please. So I'll take us through domestic demographic trends in the use of IUDs over the past 15 years or so, and I'm primarily going to be focusing at the national level here in the United States. I'll touch on some demographic characteristics that have historically been associated with IUD use, and then briefly review some factors that have influenced changes in the use of the IUD over this time frame. I want to note one point about the data and the findings that I'll be sharing today. When the data are available, I'll share IUD-focused data, but some data are on IUDs grouped with implants or LARCs. And so I'll do my best to call attention to which method or method group I'm speaking about on each of the slides. Next slide, please. Before we look in more detail at the more recent 15 years or so, let's briefly take a look back at how the use of IUDs has shifted since the 1960s. So to orient you to what you're looking at here, you can see 3 lines in blue, orange, and gray, each representing the percent of IUD use among different populations. These data represent national level data coming from the National Survey of Family Growth. The blue line represents IUD use among all reproductive age women. The orange line represents IUD use among all contraceptive users, and the gray line represents IUD use among users of reversible contraceptive methods. So you will note the trend of a rapid increase in the 1960s and 1970s until we had the Dalcon Shield, and then the subsequent falls in use in reaction to that particular method and when it was pulled off the market. And then you can see the story that you're all very familiar with here in this audience. Over the past 15 years or so, there's been a very marked increase in the use of IUDs in the United States, such that as of the most recent data, and that comes from 2015 to 2017, 13.5% of contraceptive users in the United States reported using an IUD, and that represents about 5.3 million women across the country. Next slide, please. So this gives you a little bit more detail on how those shifts in use happened over the past 15 years in relation to the use of other methods within the broader method mix. Again, these data come from the NSFG, and the metric of contraceptive use represented here is the single most effective method used among contraceptive users during the month of interview. So in these pie charts, IUDs are grouped with implants as LARC methods. And this is the breakdown in method use among the approximately 60 to 64% of all reproductive age women using contraception across the past few waves of NSFG data. So not surprisingly, again, to this group, what stands out most is the growing piece of pie represented by LARC use in these pie graphs. And at the same time that LARC method use is increasing, you can see that use of pills and female sterilization are decreasing. Next slide, please. So here we're zooming out to look at contraceptive use among sexually active women of reproductive age not actively seeking pregnancy. And here, contraceptive methods are grouped by effectiveness based on that effectiveness chart from the CDC that Dr. Dehlendorf shared, with LARCs again here represented and outlined, including both IUDs and implants. You have SARCs that are the short-acting reversible methods like pills, patch, ring, and shot, and less effective methods at the top in blue, including condoms, withdrawal, fertility awareness-based methods, and other quarterly-based methods. So again, over the 15-year period shown here, overall contraceptive use among sexually active women not seeking pregnancy stayed steady at around 90% of this population. And you can see the converse of use, or non-use, represented in the red box along the bottom. So the pattern that you see here is the increase again in the use of IUDs over the time period represented. But in this particular graph, I want to draw your attention to 2 key points that are happening as well. You'll see the red box at the bottom represents non-use among sexually active women of reproductive age who aren't trying to get pregnant. And you'll see that red box doesn't change at all over this time period. You'll also see that the blue box along the top, which is use of the less effective methods that I referred to before, not changing at all during this time period. And so I want to highlight that shifts in use during these past 15 years or so represented here are all occurring within the most or moderately effective method groups. So between pills, patch, rings, shots, IUDs, implants, and the permanent methods. Next slide, please. We talk a lot about LARC methods as a group, and I've shared data represented as such, but it's key to break out method use within the LARC group. And over the past 15 years or so, among contraceptive users, IUD use has really represented the majority of LARC use. However, just in the most recent time frame, at the national level, you can see that the implant is growing in popularity among LARC users. In these latest data, and again, these latest data represent the 2015 to 2017 time period, about 3/4 of LARC users were IUD users and 1/4 were implant users. Next slide, please. To further break out LARC users, here's the share of LARC users broken down by what type of IUD they were using and the implant. And these data come from the 2013 to 2015 data, so you can imagine that it's continued to shift since this time period. In this time period, you can see that the hormonal IUD is the most popular, and there are more options for hormonal IUDs, as you know, followed by the non-hormonal copper IUD and the implant. Among just IUD users, about 73% of them during this time frame used hormonal IUDs as compared to 27% using the non-hormonal copper ones. Next slide, please. So I want to briefly just touch on how characteristics associated with LARC use have shifted as the use of LARCs overall has increased over the past 15 years. So LARC users, and particularly IUD users, used to be a much more homogeneous group of women, often reflecting sexual or reproductive health characteristics that are associated with some of the clinical eligibility criteria for the method, like parity. For example, here we're looking at the use of LARCs by age over time. And in past time periods of NSFG data, older age or women in the older age groups among reproductive age women used to be associated with higher use of LARCs as compared to younger women. And whereas in the most recent data, we've seen that LARC use has increased across all age categories, there's been a much more rapid increase in the use of these methods in the most recent years among the youngest age groups, so that now women ages 15 to 29 years have the higher rates of LARC use as compared to their older counterparts. Next slide, please. It's also important to point out that for at least the past almost 10 years, income levels have not been associated with LARC use. And that wasn't the case back in 2002, when lower income women had higher levels of LARC use than higher income women. Next slide, please. Nor is race ethnicity associated with use anymore, although it used to be back in 2002 when women identifying as Hispanic had much higher levels of LARC use than other racial and ethnic groups. So you can see that today's LARC users are now a much more heterogeneous population of women than in years past. Next slide, please. And when you look specifically at IUD use, and this is looking specifically in the 2015 to 2017 time period, among contraceptive users, we ran multivariable logistic regression models to identify key characteristics associated with IUD use. And we found that having sought family planning care in the past year prior to interview, being a college graduate, and having given birth were all associated with higher levels of IUD use than the counterpart groups. Being in the highest age category measured, so compared to 15 to 19-year-olds, if users fell in the higher age categories, they had lower levels of IUD use. And previous research has shown that this age finding is because a large share of these older users rely on female sterilization, although fewer now than they did in the past, if you recall the previous slides. Next slide, please. So very briefly, I also just want to give you a sense of some patterns in LARC use at the state level. And so these data come from the Behavioral Risk Factor Surveillance System. And here we're looking at use among a slightly different age range of reproductive age women. Here the data focus on 18 to 49-year-olds. And we have data from 2017 from about 40 states that implemented the family planning module under the BRFIS surveillance system in 2017. So based on these data, you can see that the highest LARC use across the states among sexually active women not trying to become pregnant occurred in Oregon, Utah, New Mexico, Alaska, and Maine. And I will just remind you that for the grayed out states, we don't have any data. So there may be states that you would think would have high rates of LARC use, excuse me, but we just don't have data to reflect that at the state level. Next slide, please. So much has been written and discussed about why we have seen these marked increases in the use of the IUD in the past 15 years or so, and much of the contributions around that have been done by fellow folks in this panel as well as folks in this audience. But there have been several factor groups that people have pointed to that really contribute various pieces to this increase. And I'm just going to very briefly name a few. So at the product level, of course, we know there have been just more options for IUDs coming onto the market. And with those options coming on, we've seen increased direct-to-consumer marketing. At the patient level, as more people are using these methods, people are sharing their experiences. And if they are satisfied, they're often through word of mouth sharing that they're satisfied with these methods. And that's influencing use. Of course, broader social media and public media attention to these methods, as well as how method use has increased, has played a role. We know from this audience in particular that provider level factors like increased training around LARC methods, professional academic societies coming out and endorsing these methods for certain groups of women, as well as updating evidence and protocols to reflect the best evidence around safety and efficacy for these methods. At the structural level, we have a few pieces that we can point to in terms of the Affordable Care Act and the contraceptive coverage guarantee under the Affordable Care Act being associated with more women being able to pay $0 out of pocket between the time before the ACA was implemented to after the ACA was implemented. And of course, we've heard about and know about both state level programs as well as other specific initiatives that have focused on increasing access to the broad range of methods, but really centering LARC methods within their programmatic initiatives. So in tandem with identifying the factors that contribute to the increase of use, it's important to consider that barriers to access to IUDs also occur at each of these levels. However, as Dr. Perritt reminded us right at the beginning of this symposium, addressing barriers to access must come from the place of centering patient preferences and stated needs for the methods, whether or not these are the most effective methods. So I don't have time now to delve deeply into those barriers, but perhaps we can hear more about that in the discussion. Thanks very much for the opportunity to share the data with you today.
Thank you very much, Megan. Our last presenter is Dr. Yan Che from China. He is a faculty member at the prestigious Shanghai Institute of Planned Parenthood Research. Now, as Dr. Moazzam Ali explained previously, IUDs are used by about 40% of Chinese women, which is about 140 million users. Because of the sheer numbers of users, China is always seeking to develop new products that may perform better than existing ones. So Yan Che made a video for us that we're going to start at this time.
And friends, I'm grateful for the opportunity to present at this IUD Symposium. Thanks, David, for your invitation. Today, I will talk about IUD usage and the devices in China. The prevalence of contraception in China is very high. It's above 80% during last decades. The prevalence of IUD use was about 47 to 48% before 2015. After that year, it's about 42 to 44%. So IUD accounts for more than 50% of contraceptive use in China. Today, we have over 100 million IUD users, accounting for about 2/3 of the global users. The first generation of IUD used in China is made of stainless steel wire. This slide shows you 5 earlier stainless IUD, ring-shaped IUD, uterine-shaped, twisted ring, steel plastic IUDs. These IUD were no longer in use in China because of their high failure rate and exposure rate. The other version of copper IUD were a combination of first generation IUD with copper wire. A piece of copper wire was placed into the ring, and steel plastic IUD formed the copper ring and the copper steel plastic IUD. And a piece of silicone rubber with indomethacin was added to the copper ring and formed the medicated ring. These three types of IUD were not included in the national family planning programs because of their exposure rate are relatively high. In next few slides, I will show you several IUDs that are currently used in China. The first one is uterine-shaped copper IUD. Several pieces of copper spiral wire were placed inside of the uterine steel ring. The surface of the copper is 200 or 300 square millimeters. Indomethacin can be loaded in the device and formed a medicated uterine copper IUD. And the Yuangong IUD was developed in China in 1992. There are two types of Yuangong that they use the same material as uterine copper IUD, but with different shape. The copper surface of type 1 Yuangong IUD is 220 or 300 square millimeters. For the type 2 Yuangong IUD, the surface area of copper increased to 365 square millimeters. The medicated Yuangong copper IUD is loaded 20 milligram indomethacin, but for the type 2 Yuangong copper IUD, loaded 25 milligram indomethacin. Today, both of the uterine-shaped and the Yuangong copper IUD were widely used in China. A gamma copper IUD is another very popular device. There are two versions of gamma copper IUD. Type 1 developed in 1985. The material of the product is the same as above, but it's gamma shaped. The surface area of copper is 200 to 20 or 300 square millimeters. Type 2 gamma copper IUD was invented in 2000. Memory alloy wire used to form the shape of the device, which is placed inside of the spiral steel wire. The shape of the memory alloy can be changed when the temperature is below 50 Celsius degree. When the temperature is above 35 Celsius degree, the shape of the device can be restored. So one advantage of this device is that there is no need to dilate cervix for IUD insertions. The surface area of copper of type 2 gamma IUD is 250 square millimeters. Type 2 gamma copper IUD contain 25 milligram indomethacin. Flamless fixed copper IUD use was invented by a Belgian doctor. It was introduced to China by WHO in 1990s. The medicated Genefix is loaded 28 milligram indomethacin. A new type of Genefix called Genefix PP was approved for use in China in 2002. It was designed particularly for postpartum women, and this device has a degradable conical head, which helps the device to echo the uterine to prevent IUD exposure. Both of the Genefix and the Genefix PP IUD are very popular in China. Copper-T IUD, Copper-T 220C and 380A were introduced to China in 1980s and 1990s. I think you know much about these two devices, so I won't talk too much about them. But Chinese experts modified the end of copy 220C like above at the 3 end. We call it copper T220C 3Q. 3Q means the 3 ball end. The copper T220C and the copper T220C 3Q are popular version of IUD used in China. But copper T380A is not very popular in China today, although it's very popular in many other countries. Multi-load copper IUD was introduced to China in 1984. It is still in use in China, but not very popular. A multi-load copper 250 also introduced to China, but it's no longer used in China today. There are several other versions of copper IUD, including the M copper IUD, H copper IUD, V copper IUD, but the number of users is very small. I won't talk too much about them. Next, I will show you some results of the studies with good quality, which compared effectiveness and safety between different IUDs. A large RCT study was conducted in 2004 to compare the effectiveness and safety of 7 types of IUD commonly used in China. As shown in this table, the 1-year rate of pregnancy was significantly lower in medicated Yuangong and medicated gamma copper IUD than others. The 1-year continuation rate for medicated Yuangong and medicated gamma and copper T220C were about 95%, which were higher than other 4 devices. This slide shows you the result of a systematic review. With respect to the rate of pregnancy, expulsion, and continuation, medicated gamma copper IUD were all super to copper T220C. The pregnancy rate and the expulsion rate of medicated gamma IUD were similar to UT9-shaped copper IUD, multi-load 375 and copper T380A, and also V copper 200. But the removal rate due to medical reason and the continuation rate were favored gamma copper 200. This slide shows result of another systematic review. You also concluded that the effectiveness, safety, and the continuation rate of Genefix 330 were similar to those of copper T380A, but super to copper T220C. As I have discussed above, endomethacin is loaded in many versions of copper IUD to prevent side effects. A study in 38 women showed that the menstrual blood loss in medicated gamma copper IUD were lower than that of copper T220C users during the first year. But the blood loss of the 2 devices were similar before IUD insertion and at the 24 months of use. Comparing the use of Genefix IUD without endomethacin, the menstrual blood loss is significantly lower in medicated Genefix users at the first and the 3rd months of use. The blood loss in medicated Genefix users was almost not changed within the 6 months of use, but the blood loss in the non-medicated Genefix is significantly higher after than before IUD insertions. A popular medicated IUD used in China today include medicated gamma copper IUD, medicated Yuangong copper, medicated Genefix, medicated UT9-shaped copper IUD. There are multi-million IUD insertions and removal performed in China every year. As shown in these tables, the net increase IUD use was more than 4 million before 2015. After that year, the annual net increase less than 1 million. This result is probably due to the relaxation of the Chinese strict population policy in 2016. Many contraceptive users switched to the short-acting method, in particular condoms. That's the end of my presentation. Many thanks for your attention.
Okay, well, I hope you all enjoyed that presentation from Dr. Yan Chen. Che, and now we have a few questions from the audience. And Moazzam, I think there's a question for you, if you can just respond to the question about services and access to services. Is that for both insertion or removal, or is you just don't know?
Can you kindly repeat the question?
So the question from one of the participants is whether when you spoke about access to IUD services, were you referring to access to insertion of IUDs or access to removal of IUDs, or you just don't know?
No, it was, thank you for the question. It was both insertion and removal. I mean, making it as a package of IUD insertion and removal. So it was not only insertion or, removal was not separated. So it was together.
Okay. And also, Carolyn Westhoff, noted how the prevalence of IUD use in many of the countries in your slides really decreased significantly over time. And, her question is, well, is this because of government programs, access, donor-driven issues, or are all of these changes driven by real desires of users and women's preferences? Do we know what the real drivers are for the decreasing use of IUDs?
I think it's not easy to answer this question. I mean, it's I would say a combination of all these factors. When we look at some countries where the IUD prevalence is high, we see a very supportive policy at national level. As I've mentioned, in some countries, the former USSR countries, in China, in Vietnam, Palestine, the prevalence is more than 40%. Then also, I think in other countries, it is not very supportive in some countries. And also, as I mentioned, there are provider biases. There are also challenges in the skill set of the providers in insertion removal because of the low number of cases that come to them for IUD insertion and removal. So they lose confidence. And finally, I think it is also to do with the providers because, as I mentioned earlier on, the familiar become desirable, and if it is not common in a particular community, IUD may not be even if it is offered, it may not be taken up. And we did a publication in which it was highlighted that many women would not prefer an IUD because they feel that having something in the body, inside the body, is not very comfortable for them. So it's a combination of the national policies, the provider skill set, and also the clients who are receiving these services.
Okay, thank you. And Megan Kavanaugh, there was a question for you. When you looked at factors associated with increased LARC use, you had several different characteristics of users that came out in your analysis. Did you happen to look at insurance coverage and the possible association with LARC use?
Yes, and I actually put a paper in the chat that shows the association of having any insurance coverage with the use of all different methods, both grouped in different ways. And that was using the state level data, the BRFIS data, which we think is a little bit better level at which to be looking at the associations between insurance coverage and any use of any method. We did look at insurance use in the national level data as well, but we combined it with having gone and gotten care at a family planning site, and we considered either having insurance coverage or having gone and gotten care at a family planning site as quote unquote an access to care variable. And we did find specifically for IUD use that having either of those types of access to care was associated with higher levels of IUD use.
Okay, thank you, Megan. There was a question for Yan Che about how you remove the Chinese IUDs that do not have strings, and I can answer this quickly. Chinese have developed a very slender tool that is inserted through the cervix, and on the very tip of it is a small little I want to call it curved piece that is used to grab the IUD and pull it out.
All right, we're at time for today.
Okay. So I think, yes, we're done for the day, and we're going to pass it back to Carolyn. If there are extra questions, we'll be providing answers to some of those on the website in the future. So back to Carolyn.
I want to thank all the panelists for their contributions today. And I know that yes, it is complicated, right? Both being patient-centered is very complicated, and figuring out exactly why the numbers are going up and down is pretty complicated. I really appreciate that the speakers were kind of bouncing back and forth across each other's points. I don't know whether we're going to answer all those questions even by the end of our symposium, but it's important for all of the audience to know this is not simple and obvious. I want to again thank our corporate supporters for helping make this possible, and remind everybody that the next meeting will be Wednesday, December 9th, and we will give you the the timing and the lineup on the website soon. The recording from today's meeting will be up on the website within a couple days as well. And so thank you all for participating, and we'll see you in December. Bye.